Hello, this is Chris Ferrigno. In this video, we'll be discussing the hip joint. This will be the first of three discussions on the joints of the lower extremity. Let's start with a broad overview of the hip joint, which is formed by the articulation between the femoral head of the femur within a relatively deep acetabular hip socket, as we see here. Because of this depth, the hip joint's rather stable, as we can see here in this stability-mobility diagram. However, it also moves in plenty of directions, so it's rather mobile, but not as mobile as the shoulder joint. Because of its ball and socket anatomy, the hip joint moves in all planes. While the hip joint has inherently less overall mobility than that of the shoulder, it is much more stable. In the sagittal plane, the hip joint flexes and extends. In the frontal or coronal plane, the hip joint abducts and adducts, and in the transverse plane, the hip internally rotates and externally rotates. Note that a consequence of internal rotation of the hip is that a foot is internally rotated or appears internally rotated as well, while external rotation of the hip appears as external rotation of the foot. If you combine multiple planes, you want to move your foot around in a circular pattern, we call that circumduction. There are three additional concepts I'd like to point out. First, exactly where the hip joint is located. Many patients will point to their lateral leg, hip, or trunk to describe their hip. Certainly this is the hip region, but the hip joint is located further medially up in this region. Second, I want to point out the orientation of the acetabulum, which generally faces laterally and slightly anteriorly. Lastly, I want to note that the hip joint is remarkably stable for being a ball and socket joint while still providing plenty of mobility. Similar to the shoulder, the hip joint moves in all three planes. In the sagittal plane, the hip joint flexes and extends. In the frontal or coronal plane, the hip joint abducts or abducts, or adducts or adducts. And in the transverse plane, the hip joint internally rotates. Here we can see some internal rotation, or externally rotates. Note that a consequence of internal rotation at the hip joint is a foot that appears turned in, while a consequence of external rotation is a foot that appears turned out. But the motion is generally occurring within the hip itself. Picture D here shows a combined planar motion called circumduction. So let's take a minute to further explore the acetabulum. The inferior margin of the acetabulum is incomplete as the acetabular notch. The acetabular fossa forms the floor of the acetabulum. With the exception of the fossa and the notch, the remainder of the acetabulum is lined with hyaline cartilage for articulation with the head of the femur. Like the glenohumeral joint at the shoulder, the acetabulum also has a fibrocartilaginous labrum that attaches to the acetabular rim and helps to deepen the socket by about 10 to 15%, making it a much deeper concavity compared with the glenoid fossa of the shoulder. Of course, this deepening of the concavity by the labrum increases the stability of the hip joint, important for its responsibilities in weight bearing, ambulation, and other functional tasks. The hip joint or femoroacetabular impingement is a synovial joint surrounded by a joint capsule which is lined with synovium. Here we can see that joint capsule just outside the labrum in this area. And again, this is lined with synovium, or of course that's called a synovial lining, which ultimately produces synovial fluid. The head of the femur is also covered in hyaline cartilage, which is thickest over the areas which bear considerable weight. The exception, however, is right in this area, and that's called the fovea, the pit in the head of the femur for the attachment of a ligamentum teres femoris, or the ligamentum to the head of the femur. This is a relatively weak ligament that extends from the acetabulum over to the head of the femur. Running within this ligament is a small artery known as the foveal artery, or the artery to the head of the femur, that contributes to the blood supply of the femoral head in the immediate vicinity of the fovea. The transverse acetabular ligament, seen here, bridges the acetabular notch and joins the two ends of the acetabular labrum. This ligament consequently forms the acetabular foramen through which the nutrient arteries, i.e. the foveal artery, and small nerves pass to supply the hip joint. The blood supply for the hip comes from several sources. We already saw the foveal artery contained within the ligamentum teres femoris serving the proximal femoral head. This vessel originates from the obturator artery. Now we'll take a closer look at other vessels, including the lateral circumflex and medial circumflex femoral arteries. These come directly off the deep femoral artery, which is a branch off of the femoral artery soon after it passes through the inguinal ligament. As these circumflex branches are wrapping around the femoral neck, they give off what we call retinacular branches. These retinacular branches are the primary vasculature for the femoral neck itself and for much of the femoral head, with the exception, of course, of that area surrounding the fovea of the proximal femur. The largest contributor of these retinacular arteries is the medial circumflex femoral artery. Being the longest bone in the body and serving as a weight-bearing structure, you can imagine the femur undergoes high amounts of stress due to the torque placed on it. This can lead to fractures, often at the femoral neck where forces are high. Fractures are extremely common in the elderly when bone quality diminishes and falls are common. In the younger population, fractures are more common during high force trauma, such as falls from great heights or motor vehicle accidents. Often, fractures are repaired by plating and pinning the bones in place, sometimes due to poor bone quality or due to an osteoarthritic joint. The joint requires replacement. During this procedure, the femoral head and neck are excised. The acetabulum is reamed out and replaced with an acetabular lining, and then the femoral neck is implanted along with a ball on the top of that femoral neck. If the circumflex vessels are compromised, for instance in the case of a femoral neck fracture or in the case of a very large vertical or axial impact, the cells in the proximal head of the femur can die, developing a condition known as avascular necrosis. It's important to note that any bone can undergo avascular necrosis, also known as AVN, but the femoral head is the most common area for this to occur. Other common sites include the humerus, the knee, and the scaphoid in the hand. Like all joints, the hip joint is surrounded by a robust joint capsule. 3 ligaments reinforce this external surface of the joint capsule to strengthen and stabilize the hip joint. The iliofemoral ligament reinforces the hip anteriorly and superiorly. This ligament has an inverted Y-shaped appearance and attaches from the AIIS of the coxal bone superiorly to the intertrochanteric line of the femur inferiorly. It is quite strong, resisting hyperextension, which comes in handy during routine standing, since when this ligament becomes taut, it screws the femoral head into the acetabulum upon extension of the thigh. The iliofemoral ligament is clinically known in orthopedic circles as the ligament of Bigelow. Inferiorly, the pubofemoral ligament is triangular shaped and passes from the pubic bone to the femur where it blends with the iliofemoral ligament. It reinforces the hip inferiorly and anteriorly and prevents over-abduction of the hip. Posteriorly, the ischiofemoral ligament spans from the ischium to the femur, it reinforces the posterior aspect of the fibrous joint capsule. It's the weakest of the three ligaments, making the hip joint vulnerable to posterior dislocation. I'd like to reiterate two concepts with the hip. One should note that the fibers of all three ligaments are oriented in a spiral fashion around the hip joint. What this means is that when the hip is in full extension, these ligaments become taut. This orientation stabilizes the hip joint and reduces the amount of muscle energy required to maintain a standing position. Therefore, when a patient has very weak hip muscles, particularly those in the gluteal region, they will often stand in an extended position with the pelvis jutting forward. When flexed, conversely, such as when sitting, the ligaments become flaccid, creating two weak spots, seen here in orange, in the joint capsule. These two weak spots, anteriorly between the iliofemoral and pubofemoral ligaments and posteriorly between the ilio and ischiofemoral ligaments, contribute to the vulnerability of the hip joint, particularly posteriorly. There are three common clinical scenarios related to the vulnerability that leads to hip dislocations. Two of them are on this slide and the third is on the next. A congenital or developmental dislocation occurs when the acetabulum is insufficiently shallow and results in the femoral head that cannot seat itself properly. In approximately half the cases, this occurs bilaterally, and girls are much more affected than boys. There are a few clinical indicators for this. Because the femoral head sits higher in the acetabulum, you see one leg being shorter than another, and that manifests itself when you bend the knees and you look from down by the feet, that one knee sits higher than the other. To test for this, the Barlow maneuver is performed. A positive test occurs when the femur is easily dislocated when pushing the femur posteriorly with internal rotation, and there's often an associated audible click. A click also might be palpable and heard when you push the femur back into the acetabulum. This is called the Ortolani's click sign. This is typically outgrown and takes care of itself, although some casting may be indicated. An acquired dislocation typically occurs during very high impact scenarios or injuries, such as during an automobile accident or during the landing from a fall of great height. The femoral head dislocates usually in that posterior direction between the iliofemoral and ischiofemoral ligaments. Once dislocated, the thigh assumes a position of slight adduction and internal rotation. A third common clinical scenario for hip dislocation is after hip replacement surgery, since the decreased integrity of a new joint enhances its vulnerability. Depending on the surgical approach, a series of hip precautions are often prescribed to help prevent a mechanical dislocation. Such precautions include restricting a patient to less than 90 degrees of hip flexion, as seen here in these two pictures, avoiding hip internal rotation past midline, and avoiding hip adduction past midline. Of course, these precautions make normal activities of daily living very difficult, especially putting on socks and shoes, as well as sitting on low surfaces such as a sofa. Femoacetabular impingement, or FAI, is a moderately common hip disorder in the young active population. However, it is a relatively new diagnosis, so much so that when I first started my clinical practice in the late 90s, it didn't exist. If the acetabulum is enlarged by excessive spurring, as we see here in this picture, the socket may come in contact with the femoral neck at the end range of hip motion, particularly in hip flexion, which ultimately impinges the structures that are in the way, usually the superior labrum and possibly some articular cartilage. This is called a pincer lesion. Similarly, the spurs on the superior aspect of the femoral neck, as we can see right up in this area and here in the illustration, may come in contact with an otherwise normal acetabulum, irritating, again, any soft tissue structures in the way. This is called a CAM lesion. Sometimes both bony abnormalities can simultaneously occur. This disorder is much more common in younger females, especially dancers. It's also more common in athletes who play hockey, particularly goalies, and in baseball catchers. This concludes our discussion on the hip joint. As always, please let me know if you have any questions or comments, or if there are any issues with this recording.